I am Dr. Mary Schroth, Chief Medical Officer at Cure SMA. With me is Dr. Nancy Kuntz, Pediatric Neurologist and Medical Director of the Mazza Foundation Neuromuscular Program at the Ann and Robert H. Lurie Children's Hospital of Chicago. She is also Professor of Pediatrics and Neurology at Northwestern University Feinberg School of Medicine. Nancy, thank you so much for joining me.
It's always a pleasure, Mary. I really enjoy helping Cure SMA with any kind of educational effort.
We are together to discuss the recent publications, Spinal Muscular Atrophy Update and Best Practices, Recommendations for Diagnosis Considerations, and the Companion SMA Diagnosis Recommendations Summary. Both documents are available on the Cure SMA website at www.curesma.org. One of the most important updates in the diagnosis of SMA over the past 6 years has been adding newborn screening for SMA throughout the United States. SMA newborn screening was recommended at the federal level in 2018 and was fully implemented in the United States in January 2024. The purpose of this paper is to provide guidance to healthcare professionals and the SMA community about this needed pathway to diagnose SMA early and processes around SMA newborn screening. So that we all understand, newborn screening are tests that are completed shortly after birth. This screening looks for more than 35 conditions that, if diagnosed and treated early, can dramatically improve a child's health and survival. Newborn screening involves taking a small amount of blood from a baby's heel a day or two after birth and sending this blood sample to a state newborn screening public health laboratory for testing. Please note that although SMA newborn screening is a significant advancement in the diagnosis of SMA, it is not perfect. SMA newborn screening will miss approximately 3 to 5% of infants with SMA due to those infants having a unique mutation on the SMN1 gene. Dr. Kuntz, what are some of the important take-home recommendations from these papers?
I think one of the things that the group that convened to develop these recommendations emphasized was teamwork. The federal government really lets every state implement the newborn screening in whatever way is most appropriate in that state. But this creates, many different protocols. In some way, the health department, the birthing hospitals, the primary care physicians, as well as the SMA specialty care centers are all involved. But they really have to be involved and have a lot of communication and make sure that as each plays their part in this detection of abnormal newborn screening results, and then leading through to follow-up, that all the communication works so that no child's left behind. And most importantly, there's the critical is to recognize and address the critical role that the individuals themselves, but here for newborn screening, the babies and their families would play in this partnership that really identifies the presence of the disorder and then leads into real meaningful and quick discussions about options for treatment and treatment planning.
Thank you. Thank you. Well, that was one of the things that came out loud and clear in this paper was just the importance of families being partners in the decision-making process, all aspects of diagnosis and treatment.
And I think one of the things that's hardest about that, Mary, is that it takes most families by surprise. They're sitting with a beautiful, robust, healthy baby, somewhat tired, but incredibly excited, only to have someone approach them and say that there's a problem. And I think it takes such energy to get over the disbelief and the barrier of accepting the fact that there's a need to mobilize and take care of something that is so silent and invisible at the moment. You have this very, very healthy baby. And so I think that's one of the very valuable things that primary care and the specialty centers can do is to really help the families, help them deal with what is actually a grieving process, going from the presumption of a beautiful, perfect baby to the reality of a beautiful baby that is still equally precious, but has a disorder that needs to be addressed. It's a hard one.
Yes, I totally agree. Thank you. Thank you for that very important point. Let's turn to what happens at that first clinic visit with the SMA specialist. Dr. Kuntz, after a positive SMA newborn screen result, what does SMA care and treatment look like at the SMA specialty clinic?
There's a little bit of variability between states and between centers because in some states, the confirmatory gene testing is part of the initial newborn screening. However, in most of the states, the positive newborn screen stops right there. And when the job, as it were, the responsibility is passed over to the primary care and SMA specialty center, confirmatory gene testing still needs to be done. But as part of that, doing that, one of the big responsibilities is to actually meet physically and quickly with the baby and the family, both so that all of the education about exactly what spinal muscular atrophy is, and then what the treatment options are, and how they might benefit the child, and also what the monitoring requirements are going to be, how it's going to impact the family, and what the potential side effects are. All those things take a long time to discuss, but it's important that that be done in person so that not only can you get to know each other and bond a bit for this project that you're going to be working on so carefully for the next few months, but also so that the specialist can examine the baby. At that first meeting, it's not only necessary to obtain the blood for the confirmatory gene test, but also to examine the baby to see if you see any subtle, small signs of involvement. And many times it's very important to get a physical therapist who's actually been trained in being very, very valid and very, very picky about grading different movements and reactions that babies can make, because that clinical evaluator assessment is many times required for pre-authorization of many of the treatments that can be offered. So that's the first part, is just sort of that first getting together and starting the process, both confirming it with genetic testing, talking about the disease and the natural history without treatment, talking about possibilities of treatment, and then getting the testing done that's needed. It's usually efficient to not only do the confirmatory gene testing, but also some testing. For example, if families are interested in gene replacement therapy, testing for any antibodies that might exist against the viral vector that is used to transfer the gene. That needs to be done and done quickly so families know what options they have for treatment. As an opportunity when the blood is drawn to look for blood counts and liver functions, and those are things that would affect selection of the treatment plan, depending on if there's any unexpected problems detected. And it also gives a baseline that can be used to monitor response to the treatment or reaction to the treatment. So it's pretty intense and pretty quick, and that it's very helpful. What doesn't happen is that the families can't get to know at that first visit all of the expansive treatment team that will be important for care of anyone with spinal muscular atrophy throughout their lifetime. So most SMA care centers have pulmonologists, many of whom have been mentored by you, Mary. Many of these centers have people who are interested in metabolic bone health and nutrition and bracing and other things like that. And exactly how we'll use these people will probably change as the natural history of spinal muscular atrophy changes. But I think all of these people really contribute to the long-term treatment plan. But the short-term treatment plan tends to be in the hands of a physician and someone to be a care coordinator, a nurse or physical therapist, or and the physician to assist the family with navigating the diagnosis and the insurance.
The other advantage of the in-person evaluation, in addition to being able to evaluate the baby and have conversations with the family, is that they can ask questions.
Oh,
They often don't even know what to ask until
yeah.
they come into the clinic and the conversation starts.
Mhm.
So that collaboration starts early and should happen throughout the care of the child.
And I want to really highlight too the value that families and I and all the other treatment centers have gotten from all the educational materials that Cure SMA has published, because again, families tend to be operating in a state of semi-shock when they first have a newborn. They're sleep deprived, they get all of this information. No matter how much you explain it and review it and answer questions, it's very, very likely that more questions will come up. And or when the extended family members want more information, to have all the wonderful guides that you've put out, not only in English, but also in Spanish, has been really, really very helpful. Because people want to read. And so for me to say, if you want to Google, if you want to go into web surfing or whatever, let me give you a very reliable place to get some information, and then send them to your website. And that's been an incredible help over the years.
Thank you for that sharing. And I will just say that we actually have many of our materials in 13 different languages that are downloadable from our website. So yeah.
Wonderful.
Dr. Kuntz, how should we be describing SMA in an NBS identified infant and prior to treatment? Things have changed so much with having newborn screening and disease modifying treatments available.
Well, I think it's absolutely delightful that the natural history of spinal muscular atrophy in individuals after these disease targeted treatments has changed so much that we can't use the same way to talk about our patients and our families with SMA. I'm sure that there will be ongoing work on this with a lot of validation and study, but I think for the moment we should just start by describing each child as beginning with their SMN2 back is a gene, in the number of copies of that backup gene as the first part of the description, and then describe what their state is. And if they're a newborn, we could be clear about whether we think they have no symptoms and therefore their exam is pretty typical for a newborn, or whether they have any subtle signs discernible to somebody who's very, very critical at doing neurologic exams on newborns. But you already made mention of the fact that 3 to 5% of all individuals will not be picked up by newborn screening. So not just in the past when there wasn't newborn screening, but even from now and into the future, there will be individuals who will be picked up when they are symptomatic. So I think in addition to their backup copy number of SMN2, we should describe their state of their motor skills, what their state of mobility and ambulation is. And age at symptom onset or age at beginning treatment, or specifying the treatment, something along those lines. I'm sure that will be refined over time. And all of these things together will give kind of a composite picture of the severity of the state of their spinal muscular atrophy.
And as you're saying, these are descriptors that are in process, in evolution, in the SMA community, both across the healthcare provider community as well as our SMA patient and caregiver community. So more to come on that. Thank you, Dr. Kuntz, so much. To summarize our Secondly, optimal initial management of newborn screening identified infants requires communication, collaboration, and coordination across the newborn screening laboratories, primary care professionals, as well as the SMA specialty care team to diagnose and treat a child with SMA as quickly as possible. Early diagnosis and treatment will provide the best outcomes. And finally, infants with SMA prior to treatment should be described by SMN2 copy number, level of motor function, age of symptom onset if present, and severity of symptoms. Dr. Kuntz, thank you so much for joining me in this discussion. For more information, please visit our website at www.curesma.org.